Today I have been trying to give this talk for the last 2 years, and it's a very difficult talk to put together. I must have worked quite hard, and like before, I want to thank Chana because she gives me so much free time whenever I need to put something together. Thank you. A big round of applause for her would be good. So by a show of hands, I want to see how many of you are interested in atrial fibrillation. Oh, wow. I didn't realize that. So I want to explore with you, this is a kind of a detailed talk, and if it gets too long or if areas get boring, I may skip. But I want to discuss many aspects of it. What is it? How frequent it is? Why do we need blood thinners? Why does it increase the risks of stroke and death? What is the benefit of drug treatment? What is the benefit of ablation? And then finally, if anybody has heard about a Watchman device or an Amulet device, how many of you have heard about Watchman? So few of you have heard about what Watchman is. I think it's important for all of us to learn about Afib. So Afib is an irregularly irregular heart rhythm compared to a regular rhythm which is on the right-hand side. And if I were to explain it further, this is how the regular rhythm starts in someone. You have an area in the heart which is, I think this works, there will be a cursor that will show up there. Is it showing up there? No? Okay. Well, I'm scared to change it to dual display, but I'll do it. Let's see if it does it. Okay. Do you see the cursor there now? Yes. Okay. So the heart rhythm starts in a pacemaker, a natural pacemaker of the heart. It's called SA node. We don't need to remember that. But then it goes through natural electrical fibers to a relay station between the upper and lower chambers. You'd be surprised to know that the upper and lower chambers are electrically isolated. There is no electrical connection between them except for this relay station. And from this relay station, then specialized fibers activate the heart in less than 100 milliseconds, which is 1/10 of 1 millisecond. But what's happening in Afib is that instead of the beat originating in the natural pacemaker, there are several areas where the beat is originating. It's originating all over the atrium. So in other words, the atria starts fibrillating. They are quivering at about 400 beats per minute. And if it were not for the relay station, the lower chamber will beat so fast that all of us will be dead if we had Afib. But the relay station slows down the rate of conduction. So instead of 400, in somebody who has a normal relay station, it goes down to about 110, 120 while you're resting. And if you're excited, like giving a talk or excited for other reasons, it can go up to 150 to 180 beats per minute. So obviously that's not good for us. So irregularly irregular rhythm versus a regular rhythm like that of a metronome, it can cause people to have fast heartbeats. They'll notice their heart beating fast. You can get fatigued because the heart is not functioning efficiently. It can cause shortness of breath. In people with blockages, it'll lead to chest discomfort. Sometimes people get lightheaded and dizzy. And then, of course, you can't do the same degree of exercise because when you exercise, the heart is functioning so inefficiently that it speeds up and the heart doesn't fill well to pump well. So what causes Afib? I mean, there are a laundry list of causes, but we'll go through the important ones. Long-standing high blood pressure in susceptible people. Not all people with high blood pressure are susceptible, some are. So long-standing high blood pressure in susceptible people is perhaps the most common cause. The second most common cause is heart failure. If you have congestive heart failure, you can have it. Now there are non-heart related causes. One of them is increased thyroid activity, people who have an overactive thyroid. Another very common cause is becoming heavier and getting sleep apnea. So obstructive sleep apnea is a very important cause. Now there are other causes that we bring it upon ourselves that can also cause AFib, and one of them is called the holiday heart syndrome. So how many of you know what a holiday heart syndrome is by a show of hands? So Suzanne does. Guess.
Drinking and drugging over the holidays.
Alcohol. So alcohol is an important cause. I stopped it. I have magic. And then, of course, sometimes things like drugs that you take, cocaine, like Jean mentioned, and stuff like that can also cause it. So let's explore alcohol. Alcohol is very interesting because the number of people with AFib in whom physicians discover that alcohol is a cause is very common. So this group of investigators took people who had previous AFib, about 106 of them, and they did two things to them. One is that they put a heart monitor, which is called a Zeo patch. Many of you may have had a 7-day monitor, which is like a patch, which you see on the chest wall out here. And the second thing that they did is that they put in an ankle bracelet, which is an alcohol sensor. It's made by a company called Scram. In these 100 individuals, there were 56 episodes of AFib during the monitoring period. And what was found is that if you had one drink, you had 2 times the likelihood of having AFib. And if you had 2 drinks, it was about 3.5 times the likelihood of having AFib. Now, we prescribe magnesium over the counter to several of our patients. And this is exploring why magnesium is a low magnesium can cause it. So this is from the Framingham Heart Study. It looked at about 3,500 patients. And what they found is that if you were in the lowest tertile of magnesium, if your magnesium level was in the bottom 25% compared to the top 75 to 100%, you had about a 50% more likelihood. Not a lot. But can I ask you, who would have low magnesium levels? Alcoholics. So, this study is probably telling you the same thing I told you before. Now, there are several types of AFib. One is called paroxysmal. Paroxysmal means you get it and you get back into regular rhythm within a few hours mostly, but definitely within 7 days. Either on your own, like you go and sleep, you stop alcohol, you rest, or with some drugs. Persistent is when it lasts more than 7 days, but can be converted. Now, long-standing means over a year. Permanent AFib means that your heart is going so repeatedly into AFib that both the doctor and the physician have decided, and the patient have decided that we'll leave you in AFib permanently. Now, this is an underestimate. I think that this is not accurate. This is the prevalence of AFib as we age. Of course, it increases. And I think if you take average 70-year-old people, I don't think that the prevalence is close to 6%. I think it's more like 10%, at least of paroxysmal AFib. And when you get into the 85 age group, I think paroxysmal AFib is upwards of 25%. So when you have AFib, what does it do? Does it increase the risk of stroke? Sure. And what in your makeup will show that you're also at increased risk of bleeding? The two are interrelated, because when you have AFib and you are at increased risk of stroke, you need blood thinners. And if you are at higher risk of bleeding, then you can't have blood thinners. So this is a complicated scheme of figuring out who is at risk of having AFib. Now let's say Jay, for example, is very young. I mean, I would guess that he's probably less than 40, probably in his early 30s or late 20s. Late 20s. So if he gets AFib, his risk of having a stroke is very low. So he may not need blood thinners at all. But as you get older, if you have congestive heart failure, if you have underlying hypertension, if you have diabetes, if you have a previous stroke, if you are a female, your risk of getting a stroke increases, and hence the need for blood thinners goes up. Okay? So older age, female sex, congestive heart failure, previous stroke, diabetes, high blood pressure, these are all risks. Again, I think this is a little bit of an underestimate. As the score goes up, the risk, a yearly risk of having a stroke also goes up. So if you have a risk of about 2 to 3, you're between 2 to 3% risk of stroke per year. If your score is greater than 7, probably it's over 10%. So why do you need a blood thinner in AFib? So the reason you need a blood thinner is because the upper chamber of the heart, which is called the left atrium, so this is the upper chamber, it becomes enlarged, and mind you, it is quivering. So there is stagnation of blood. But principally, the left atrium has an outpoaching. It's called an appendage. This is called the left atrial appendage. This is where the stagnation of blood is the greatest, and this is where you usually form a clot about 90% of the time. So 90% of the time, the clot is in the left atrial appendage. Now similarly, you want to see who is at risk of bleeding, because we're going to be giving blood thinners. And again, people at risk of bleeding are people with high blood pressure, people with kidney disease, people with liver disease, elderly people, of course, drugs and alcohol and things like that. So you can calculate a risk for bleeding as well. Greater the risk of bleeding in terms of this bleeding score, higher the risk of that person having a hemorrhage or bleeding on blood thinners. So we need to talk about what blood thinners to give in people who have AFib. So the common blood thinners we use, people who have stents, aspirin and Clopidogrel, and the other blood thinner that we used to use is called warfarin or Coumadin. So this is a very interesting study, and it was done right at around 2006. And it was sponsored by a company called Bristol Myers Squibb that was making Clopidogrel because they wanted to sell Clopidogrel for AFib. The AFib market in the United States and globally is huge. The amount of money you're going to make by selling an AFib drug is tremendous. But this study had a very negative outcome despite being run by a drug company. I would give a lot of credit to somebody who would give me why you think that was the case. Why did the study get published so honestly despite being done by a drug company?
Regulations?
So at that time, I don't know if you guys know about the Vioxx scandal. Vioxx scandal had come about, and then they had to pay a lot of money. The Merck company had to pay a lot of money for the Vioxx scandal to get out of it. They settled for, like, I think some billions of dollars. And also at that time, there was another study called the ENHANCE trial, which was a trial of cholesterol-reducing medicines, in which they promised enormous degree of benefit, but suddenly after the trial was started, they refused to publish that trial. So up until that time, a company could do 15 studies and only publish the one that showed their drug in positive light. But when ENHANCE trial was not being published and Vioxx things came out, people forced the government to come out with a law that when you come out with a study you got to register it with the government that you're doing the study, and at least you need to publish the data online. So this was right at around that time. So if we look at the study, about 3,000 odd patients in each group, predominantly male, about 67%. They had about quite a bit of congestive heart failure, about 30% in each group, as you can see. So, but this is kind of a standard population of people with AFib who are not very high risk. These are moderate risk people. Okay. Just the fact that I moved that, let me see if I can go to the next slide here. Next. Oh, wow. See? So the trial was stopped early because it was found that an old drug that companies make no money with was much more beneficial than Clopidogrel and aspirin. So what was found is that if you were on warfarin, you had about a 3.9% risk of having a stroke, dying, or having a heart attack or a blood clot, versus 5.6%. The risk of stroke was 2.3% with Clopidogrel versus 1.4% with aspirin. So the Clopidogrel is an antiplatelet drug. It is good for stents, but it's not an anticoagulant, which is a better blood thinner for the chambers of the heart, and that's why we were using warfarin for quite some time. Now, surprisingly, and this was very surprising to me, that even though the risk of major bleeding between Clopidogrel and warfarin was not any different, when you were on Clopidogrel and aspirin, the risk of minor bleeding was higher with Clopidogrel compared to aspirin. I would have thought the other way, that you would be at greater risk of bleeding from a stronger blood thinner like warfarin. So, anybody who's been on AFib will tell you warfarin is a difficult drug to use. You can't eat vegetables. You got to go to the doctor's office every couple of weeks and get your INR checked. And your INR fluctuates up and down. It's never constant. So it's a pain in the neck both for the doctor and the patient. So nowadays, we don't use warfarin as much. We use something called NOACs. How many of you know what NOACs are? Apoxaban or Eliquis, Xarelto or Rivaroxaban. So people know that, some of them. So we no longer use warfarin. I'm going to skip through these trials to show you that these trials compared Apoxaban or Eliquis or Rivaroxaban or Xarelto with warfarin. And what they found is that these drugs are either equivalent to warfarin in reducing strokes or better, and they are either equivalent or better in reducing the risk of bleeding. So you get both benefits. It is more effective and it is less dangerous in terms of bleeding. So we can save some time. These are just slides that show that these drugs are beneficial. One of them was Eliquis, the other one is Rivaroxaban. Okay, now let's come to the other question. When somebody is in AFib, should you convert them to regular rhythm or just leave them in AFib? So, can drugs help? How effective are such drugs? What are the side effects of the drugs? So this is a clinical trial that was done over 600 days. That's over 5 years. No, that's about 2 years of follow-up. And what was found is that among the drugs that we use, the top one is called Amiodarone, and the bottom two one of them is called Ridmol or Propafenone, the other one is called Sotalol. So the most effective drug at keeping people in regular rhythm, because here is showing that more people remained in regular rhythm over time. Here, less people remain in regular rhythm over time. Amiodarone was very effective. But how many of you have had experience with amiodarone? Anybody? Some. The doctors have had it. So amiodarone is a difficult drug to use because it can get into the eyes, it can damage your liver, it can damage your lungs. So long-term use of it, you always are concerned about it. But in terms of the heart, it is pretty safe, and it is the most effective drug we have at keeping people in regular rhythm compared to the other drugs. What are some of the problems with these drugs? See, in other words, when you take these drugs, it causes what is called chronotropic incompetence. Now, what is that? So, when I get up and I move and I go to the car, my heart has to speed up to support my muscles in terms of blood oxygen supply. These drugs slow down the heart. They reduce the speed with which the heart speeds up when you exercise. So people don't feel good about it because they'll say, hey, I feel short of breath on these drugs that I didn't used to feel. I can't do the same activity that I used to do, so I'm more tired. It slows down the heart sometimes into the 30s and 40s per minute, so that's not good. In susceptible people, these drugs can cause dangerous heart rhythms that can be life-threatening, especially in people with blockages. It can also drop your blood pressure. So, another thing to explore with Afib is that many people get what is called a cardioversion. You're taken to a lab, to the hospital. You're put in one of the rooms. An anesthesiologist gives you sedation. A couple of pads are put on you, and you get an electrical shock to get you from irregular rhythm to regular rhythm. This is called cardioversion. It's kind of a little difficult to go through all of that. Are there drugs that can also do cardioversion? So one of them is Flecainide, the other one is Sotalol. So this was a study that was done in about 106 patients who had Afib, which was relatively short duration. And what was found is that Flecainide was effective in converting them to regular rhythm about 50% of the time, IV Flecainide. Sotalol, not so much, a little over 20%. But here is the important point. If you have Afib and you come within less than a day, so you have Afib, you show up tomorrow, and there is a pill form of it also we will explore, you take the drug, you have about a 70% likelihood of converting. On the other hand, if you've been in Afib for more than 7 days, the chances of converting with the drug is almost negligible. Now we talked about whether in the olden times, back in 2000, not 2024, but 2000, the doctors were under the kind of pretext from this trial which said that when you see somebody with Afib, should you put them in regular rhythm or should you leave them in Afib? And according to this study, it said that if you leave them in Afib, it's just as good, maybe even a little better. I don't want to join guest network, right? Okay. So here is that group. So in one group, they said, we're just going to control their rate and give them blood thinner. In the other group, they said, we're going to do everything to get them into rhythm and give them a blood thinner. 70 years, 50% hypertension, about 20% had heart failure. Those are the important aspects. So the rhythm control group, this is the probability of dying out here. This is up to 5 years. The probability of dying was slightly higher in the group in which you attempted to put them into regular rhythm compared to just doing rate control, which was highly surprising. Now this is an important question. Many people have Afib, they get converted to regular rhythm, and then even I follow this practice and I'm not sure whether I should or no, because blood thinners are so expensive. Blood thinners can cause bleeding. So we say, hey, after some time we should stop the blood thinners because now you are in regular rhythm. But the problem is that up to 60% of people, and maybe even more if you do continuous monitoring, will go back into that irregular rhythm periodically. So in this group, they continued blood thinners in both groups, the rhythm control group, in which you converted them to regular rhythm, and also in the rate control group. And at the end, you found equal number of strokes. The strokes were there in both patients. So many people argue that once you have had AFib and you have risk factors for having a stroke, which means that you have a high CHAD score, that means you have congestive heart failure, age, high blood pressure, diabetes, that you should continue blood thinner regardless of whether you are in regular rhythm or no. But then it felt so bad to say to people that, hey, I really can't do anything about it. So we explored it again. We revisited the aspect that whether getting people back into regular rhythm compared to leaving them in AFib was good or no in this other trial. And it was similar, 70 years, high blood pressure was a little higher, heart failure was a little higher in this group. Now, I'll walk you through this slide. This is the group that is going through rhythm control. That means they're being put back into regular rhythm. These are the different kinds of drugs that were used in them. These are all the different drugs shown out here at 1 year when they started and at 2 years of follow-up. In the rate control group, no drugs were used. At the bottom out here is a new treatment which is called ablation. Do I dare to move that?
There you go, that's perfect.
Okay, but I don't know if I can forward the slide. See, I can't forward the slide anymore.
Just go next.
You guys know it all.
It's good. It's good.
Okay, so in this trial, unlike the previous trial, what was found is that when you put people back in regular rhythm, wait a minute, let me just go back because I got distracted. It's about 20% of people got ablation in this group, about 7% got ablation in the other group. And we're going to talk about ablation in a bit. So the chances of dying was 67 versus 94 for similar number of people. It was highly significant. Stroke was lower in the people in whom you got them into regular rhythm. So I think this is the real world of AFib in this day and age. If somebody comes to us with AFib, we're going to do everything possible to get them back into regular rhythm. Okay, so we're doing very good with time. How many of you have heard of ablation? Quite a few of you, okay. So what is ablation? So in ablation, you say that the heart rhythm called AFib is coming from the pulmonary veins. So pulmonary veins are veins that are draining from the lung, oxygenated blood into the left side of the heart. So the pulmonary veins have electrical tissue that is creates an irregular rhythm. And the pulmonary veins have another special thing that many people don't realize. They have connections from the vagus nerve. So many of you may have heard about the vagus nerve. Vagus nerve comes from the brain. It's not under conscious control. But what the vagus nerve does is that it slows down the heart. Also attached to the pulmonary veins is the adrenergic nerves. The adrenergic nerves are releasing the fight or flight hormone called adrenaline. So that speeds up the heart. So when you do an ablation, which means you make the tissue of the pulmonary veins dead by radiofrequency, by burning it, you sever the connection of the vagus nerve to the heart, so the heart naturally speeds up a little bit, and you sever the adrenergic or the fight or flight connections to the heart. So I'm giving this talk and I have high adrenaline, my heart would be less affected because it's not acting on my heart as much. Now ablation started out in the 1990s, and when I first saw that procedure being done, I said, I'm never going to recommend my patient to it. Because the catheters were bad. You have to come from the vein in the leg, get into the right side of the heart, poke a hole, find the pulmonary veins, and then burn them. The mapping system for finding the pulmonary veins was not that good. And I remember that I was in a procedure for 10 hours with my attending, trying to do the ablation, and still we were not satisfied at the end. However, come on in. However, the procedure has improved a lot. The catheters are better, the mapping system is better. Now it's the same day discharge. You go home the same day. It's an outpatient procedure. The complication rate is less than 1%, 0.7%. The procedure can be accomplished in the usual setting in about 45 minutes to an hour. And it decreases the frequency of AFib, and it reduces the amount of time you are in AFib. Okay? So now we frequently recommend ablation. So this is one of the first trials that was comprehensive. It was, I think, done somewhere around 2013 to 2017. And they took similar kind of people, usual AFib population, about late 60s, a lot of high blood pressure, some congestive heart failure. Their risk of bleeding was at about 3. The CHAT score was about 3, so that's moderate. Okay, they were not very high risk for bleeding. Now this is kind of a disappointing factor that everybody who's had ablation should recognize. That ablation is modestly good. It's not perfect, it's modestly good. So that means at the end of about 4 years, the chances of being free of atrial fibrillation was only about 50%. Whereas if you did not have an ablation, your chances of remaining free was a little over 20%. But this data is a little colored because there were 300 patients that were in this group. Remember, there were about, I didn't put how many patients, but I think there were about 1,300 patients in each group. And about 300 patients crossed over from the drug group to the ablation group because they could not live with the drugs. The drugs were either causing side effects or they were having too much AFib. But even though you will have AFib return, it is much less frequent and the duration of AFib is lower. So in other words, you won't last in AFib as long. You can get back into regular rhythm a little easier. The chances of reducing death, reducing stroke with ablation is the same as drug therapy. So you should not go through ablation thinking that, hey, it's going to make me live longer. Now, some people may come and say, well, ablation has further improved since then. We do it better and we have better technology. Not so, because this trial published in 2023, a little younger age group, paroxysmal, that means AFib lasting for less than 7 days versus persistent lasting for more than 7 days. These groups were compared. High blood pressure was less, 49 versus 65% compared to about 80% in the other trials. These people were at lower risk. So in other words, they were younger, they had lower risk of bleeding because only 19% were in the score of 3 for CHADS. This is how the ablation was done. This is called pulse field ablation. You get into the pulmonary vein, you zap it, and when you do the map, that's how the area of dead tissue looks like around the pulmonary veins that is draining into the left atrium. What were the results at 12 months? Did 90% of these people remain free of AFib? No. it was about 66%. If you were in the category of paroxysmal Afib, in other words, Afib was lasting for a shorter period of time, then your chances of success was a little higher, about 67% success, 33% failure. If you were persistent Afib, the chances of failure was 55%. Success was 45% at 5 years. I mean, at 1 year. So this is the interesting part. So many of you have heard about Watchman. And there are many people who say, I don't want to take a blood thinner. It's too expensive. Some people cannot take a blood thinner because they bleed, they have high risk of bleeding. Some people don't want to take blood thinners because they're in contact sports like football, cycling, and stuff like that. So what are my options if I don't want to take blood thinners? Because 90% of the blood clots form in this appendage, this outpoaching of the left atrium. Can this be plugged? Will it prevent strokes? Are there any side effects? And how difficult is this procedure? Now, technology is always moving, but this is something very important for this group to learn about what Watchman is. Now, I am a plumber. I'm not an electrician of the heart. Several plumbers want to put Watchman. I think it's essentially wrong for plumbers to try to put Watchman. I think electricians should put the Watchman because they cross the interatrial septum, that is the septum between the right side and the left side of the upper chamber. So they poke it on a daily basis when they are doing ablation. The plumbers don't do it often. You have to poke it in a special location to get to the outpoaching, which the plumbers don't know. The electricians do maybe about 5 to 10 procedures per month. The plumbers do maybe 1 procedure every month or 2 procedures in 3 months. So their success rate and the complications may be a little bit higher. So this is how it looks like. This is the outpoaching, that is the plug that they are putting in. When you look at it and the plug has healed, the plug has a fabric which gets lined by the inner lining of the heart, by the endothelium. So this is a beautiful situation in which it is nicely lined, it's completely sealed, and if this happens, you don't get any blood clots. But how likely is that to happen? What are the dangers of this procedure? So this was the first trial. This was called the PROTECT study. They enrolled in a 2-to-1 design. They enrolled people, 460 odd patients to the Watchman and about 240 to the control group, which was blood thinners. At that time, warfarin was the standard. The Rivaroxaban or the Xarelto were not standard at that time. Successful device implantation was only 88%. Okay, that means 12% they could not put the device in for whatever reason. 49 out of these 463 patients, or 10.6% had a complication. What was the complication? That means 1 in 10 chance of complications. There was bleeding around the heart, 22. Major bleeding in other areas, 16. Stroke, 5. The device, instead of getting into the plug, got embolized. It went into the bloodstream. The surgeon had to cut open the chest to take the device out 3 times. Because you are working in the left atrial appendage, which is very close to the feeding pipe, they tore into the feeding pipe in one of them. So they presented their data up to 195 days, about 3 years. And what you do is that you implant the device, you do an ultrasound to make sure that there is no blood clot or leak in the device, and then you stop the blood thinner and put them on aspirin alone. So these people are without blood thinners, and you found that the risk of having an ischemic stroke, that means stroke that does not bleed into the brain, was a little higher in the Watchman group compared to the warfarin group, although they said it's equal, it is non-inferior. This treatment is non-inferior. So they went to the FDA. So how many of you know how the FDA works? Wouldn't you expect that if a drug company or a device company goes to the FDA and says, hey, approve my drug, would it be right if the FDA is taking money from the drug company or the device company to review their trial?
No.
Would it surprise you that 45% of that money comes from the device or drug company?
No. Wouldn't surprise me.
Now, so that's, I think, in my mind, conflict of interest.
Yes.
Now, you would think that it's only FDA employees who are reviewing this data, but not so. The FDA then turns around and hires, hopefully, people who are skeptics like me, but very often not. So what happens is that many of these investigators are running drug and device company trials. They become a little older. They say, well, now I can have a little easier job and I can move to the FDA. So from the drug company, they move to the FDA, they have contacts. Also, you would not want any individual on this company that is related to medical device or healthcare industry, but that is the case. Sometimes these committees have medical device personnel and healthcare industries. But despite all of this, for whatever reason, the FDA said, looks like this is not a device that's ready for prime time, we're not going to approve it. So that was back in 2009. They said, go back and do some more studies. So instead of PROTECT, they started a PREVAIL trial. Similar group of people with previous strokes, heart failure, diabetes, high blood pressure, older group. 269 in the Watchman group, 138 in the warfarin group. And with experience, these people, these operators with more experience, and perhaps learning a little bit more and the device improving, the complication rate dropped from 10% to about 4.5% or 4.2%. So that's good. But still, you see that many devices embolized, one of the heart perforated, there was bleeding around the heart that required to be drained. So it was not a trial free of complications. But look at this, ischemic stroke. When these were followed up for 18 months, ischemic stroke in the device group was 1.9% compared to 0.7%. Did not meet non-inferiority, which means it was not an equivalent outcome. But what you do is that you say, okay, we're not going to count the first 7 days after the device, and we're going to count 7 to 18 months. And it showed that, yeah, it is non-inferior, so the device got approved. And so now, so what they did is they combined PROTECT trial, PREVAIL trial, and some additional registries to go to the FDA to show that these two are equivalent. And so the device got approved. And now everybody and his mother wants to put this device in. So you go to, there must be like 20-odd cardiologists in this hospital, and I think 12 of them deploy this device. Now, Watchman, you have to realize Afib is a very profitable industry, profitable disease for the industry. So Watchman making so much headway was not something that Abbott, which makes a similar device for ASD closure, could watch. So Amulet came from Abbott. So this is Amulet. It's like a clamshell device. It's got one disc that anchors into the appendage, and then there is a disc that closes blood flow into it, and it has a fabric on here so that it will seal with the new lining of the heart compared to the Watchman. So they did a large trial. Now they don't have to do a trial versus warfarin anymore, versus blood thinner anymore. They can do one device versus the other device and show that the devices are equivalent. So 900 patients in each group. The number of procedural complications was 41, 5.5%. Of this, because this device has nitinol edges that can poke through the heart, 36 patients had pericardial effusion that required them to be drained. The surgeon has to go in and put a needle into the sac around the heart and drain the blood from there. 6 devices embolized. That means 6 devices, because what you have to do is that the devices are attached by a screw. After you deploy them, you unscrew to remove the catheter out. So when you are unscrewing them, if they are not properly deployed, they get into the heart, get into the bloodstream, and 6 devices embolized. The surgeons had to fish them off. So if you are going through a Watchman or an Amulet device, it's really the case that you are paying now, which means that you're paying for complications of the device, and you may also possibly pay later with complications that I will show you. So our left atrial appendage is not a simple structure, it's very variable. Some people have a chicken wing kind of left atrium, some people have a windsocks, in some people it looks like a cactus. So you can have all kinds of imagination and give it different names. And the deployment technique, in other words, the person has to be very skilled to deploy it properly into that pouch so that the disc is flush with the opening. So like in here. On the other hand, an inexperienced operator may deploy it too far, leaving a gap where a blood clot can form, either with the Watchman or with the Amulet, or it can deploy it in a tilted manner, like here for the Watchman and here for the Amulet. So when you have a device that is not properly deployed, you can have a leak. In this pouch, the blood can flow in and out, carrying blood clots from inside to the outside, causing stroke. So you can see a leak that is shown on an ultrasound. This is color Doppler that's showing the leak. This is a CAT scan that is showing a leak. This is a color Doppler showing a leak in an Amulet. You can have another thing. In some people, instead of forming a lining on the device, you can form a blood clot. This is called device-related thrombus, DRT. So in other words, this is a Watchman device, and right here, this dark spot is a blood clot. And in here, the spot, which is kind of a dark and other consistency, is a blood clot that is floating in the bloodstream with an Amulet device. How often does this happen? Right? You want to know. Somebody who's getting this device, you ought to know how often does this happen. So these are something like 800 patients, 900 with Amulet, 900 with Watchman. They get an ultrasound at 45 days, they get an ultrasound at 12 months. Okay? So if the leak is greater than 3 millimeters, it's considered to be significant. At 45 days, it was 26% with Watchman, 11% with Amulet. At 1 year, it was 22% with Watchman and about 9% with Amulet. You would say, okay, I have a leak, no big deal. Not so. So if you have a leak, hey, Dr. Khoury.
Hello.
So in people who have a leak that is greater than 3 millimeters, they had a much greater risk of having a stroke, 3.6% versus people with a lower leak, 1.8%. They had a higher chance of dying. The chances of complications were 8.1% versus 4.7% if you had a leak. Remember how many people with Watchman had a leak at 12 months that was greater than 3 millimeters? 22%. 1 in every 5, a little more than 1 in every 5 individuals. Now this says more or less the same thing, but it was also talking about thrombus. So let me go through this to this other slide. So this is talking about a blood clot on these devices, on Amulet and Watchman, at about 13 plus 13 months of follow-up. So in other words, some people were followed up for 13 months, some people were followed for about 26 months. So this is looking at the blood clot in people who had imaging, 11% with Amulet and 5.5% with Watchman. Isn't that amazing? 11% versus 5.5%. So here is Amulet. It's showing that there is a blood clot on the Amulet out here. You can see it on the transesophageal echo. This is on CAT scan, and then another imaging technique, 3D imaging, you can see the blood clot also out there. So when I say you possibly will pay later, when the doctors and the drug companies are evaluating the effectiveness of these trials, how effective these trials are, they are failing to include the fact that there is about a 4.5 to 10% risk that you may have a complication while the device is being put in. They are failing to take into account that there's a higher likelihood of ischemic strokes. It's truly not non-inferior when you look at ischemic strokes. That there is leakage from the device, 22% with Watchman and 9% with Amulet. That increase in device-related thrombosis and increase in leaks is not just finding on ultrasound, but it also leads to an adverse outcome. It leads to strokes and the risk of dying. Now you'd be surprised to know that hospital charges are pretty nice when they put in an Amulet. Physicians really don't get very much, but they like to put it in. And Boston Scientific and Abbott make a pretty penny by selling these devices. Now, it's fair to say that, like with ablation, if you came back and talked to me about ablation in 2000, I would say, no way. Now you come and talk to me in 2024, in many people, I nudge them towards it. I say, yeah, you should go through it because it'll be beneficial. Similarly, these plugs are not at a standstill. They're going to continue to improve. Like, for example, Watchman has gone from Watchman to Watchman Flex, and now Watchman Flex is Watchman Flex Pro because it's called a hematocoat, and I don't know if it's effective or no, but it's got technology on it that will prevent blood clot formation. So it's possible down the road, I'll be standing here and saying, yeah, these devices are good to do. But in 2024, and this is an important question for many of you because many of you are a little older, you may be advised this device. I think that the only person who should get this device is a person who cannot take blood thinners because of significant bleeding risk. And in that group of patients, like let's say you are trying to get this device and you cannot take blood thinners, that's one factor. But the other factors to be taken into account is that if you have advanced heart failure, if you show slow flow on ultrasound in the upper chamber, if your upper chamber is severely enlarged, or if you have advanced valve disease, all these are harbingers of forming a blood clot on that device. So even though you may not be able to take blood thinners, don't get this device if you have any of these. Now I'm also open to giving this device to people who are doing contact sports, cycling. I have a friend who cycles, who is in permanent Afib, and I have advised him to get this device, but with an ultrasound to check that he does not have a device leak and that there is no blood clot on the device. So I'm going to go to the last slide here. What can we do to prevent Afib? Okay, so this is something applicable to all of us. The first thing would be, the biggest buck you will get is if you control your blood pressure. I'm not in favor of controlling blood pressure with medicines. I think you should do it with lifestyle. Moderate exercise, intermittent fasting, low carb diet, those are all good aspects. Moderate exercise is good to reduce Afib. People who are endurance athletes that exercise for more than 6 to 10 hours per week, as they get older, they may have up to a 10% risk of paroxysmal Afib. So in other words, people who are cyclists, and cyclists is a very common phenomenon to have Afib. Poor sleep can cause AFib. You need to have proper sleep apnea management. If you're heavy and you're snoring and you don't have sleep apnea, you are much more risk of AFib. Weight loss is important. I think magnesium works, I give it, although the data that magnesium works is not there because I think the studies are not good. And then if you get paroxysmal AFib, you should consider a pill-in-the-pocket approach, which I will discuss if somebody has a question either now or later. So I'm sorry I spoke for a long time, but I had to give you a comprehensive overview of AFib.
What's the pill-in-the-pocket approach?
What do you say, Mrs. Spencer? Is that something we want to know about pill-in-the-pocket approach? Mm-hmm. Okay. So pill-in-the-pocket approach is that you take either Flecainide or propafenone, and you take it as soon as you go into AFib. So you take about 200 milligrams of Flecainide or 450 to 600 grams of propafenone, and there's about a 73% likelihood of going into regular rhythm. But there are some drawbacks of it. The drawbacks is that there were some people who went into atrial flutter. So instead of having AFib, in which your heart is quivering at 400 beats per minute, they went into atrial flutter, which is going at about 300 beats per minute. And sometimes what happens is that the atrial flutter rate slows down because of the drug to about 220 to 250, and your AV node can conduct at 200 to 250, so you, instead of slowing down, you speed up. That can create a dangerous situation. So the doctor advising you pill-in-the-pocket approach should also give you a beta blocker to slow down the AV node. In this they didn't, so 2 people went into atrial flutter with 1-to-1 conduction that required emergent treatment. And sometimes it slowed down the heart rate too much, 2 in each group, like 1 who were in the hospital, the other outpatient setting. Some people had significant drop in their blood pressure, so it's not without risk. Pill-in-the-pocket approach should be discussed with your physician one-on-one. All safety precautions should be taken so that you are helped. All right.
No, not.